Thank you for having me. Good morning, everyone. So, let's see. Even though I am invited to speak about nursing, I start with this slide because our older people care needs are complex. Therefore, it is crucial that we are using a person-centered approach and work as a team. And don't forget to involve the nurses already when you are planning research. That can be very fruitful. So, as we heard, frailty and sarcopenia is something that many of our orthogeriatric patients has. And good intervention where nurses can be involved is our exercises and nutrition. So this book is the 6th edition, and the 7th edition will be released this fall. And I have, together with colleagues from US, UK, and Canada, updated the chapter Care of Older Adults with Fragility Hip Fractures. And I don't get any money for that, but I will say that this book is very good to have at the clinic for nurses. In the book, we are describing evidence-based interventions to reduce complication and prevent secondary fractures, which is crucial to maximize recovery, decrease mortality, and contain healthcare costs. And you see some of the complications that are common that we are describing in the book. So, all the patients with hip fractures or other fragility fractures are at high risk for unmanaged pain with highest rates of delirium, impaired mobility, and long-term functional impairment as a result. Information on pre-existing painful condition and prior pain treatment serve to illuminate potential sources of discomfort and types of pain to incorporate into the treatment plan. Assessing and recording pain intensity using a valid scale with vital signs make the pain assessment visible and help ensure that the patient is assessed on a regular basis. For patients with severe cognitive impairment, use a validated behavior scale such as the pain aid scale. A multimodal approach to analgesia helps maximize the effects of analgesics while decreasing the dose requirement of any one medication, thereby limiting their adverse effects. And a combination of geriatric appropriate opioid together with paracetamol and regional analgesia, for example, nerve blocks, may manage pain while reducing side effects such as sedation and delirium. The American Geriatric Society has updated the BS criteria for potential inappropriate medication use in older adults. Delirium can also be an adverse effect of analgesics. However, delirium is also associated with unmanaged pain. Assessing and adjusting medication or reducing the dose of analgesics are interventions that may reduce the analgesic contribution to delirium. The Delirium Elderly at Risk, the DEAR tool, is one example of screening tool that was created to identify risk for pre- and postoperative delirium in the hip fracture population. Results of recent study found a modified version at the DEAR, the MDEAR, valid to screen for delirium risk when used as a part of the nursing admission workflow for all hospitals' older adults. So the patients are not tested with a minimal mental test and not drawing clocks. The nurses are only looking in the medical record and speak with the patients. Indwelling delirium is independently associated with a number of adverse outcomes, including pressure ulcers, functional decline, institutionalization, and death. And indwelling urinary catheters, prolonged immobilization, and family environment, sleep deprivation, medication, electrolyte imbalance, and poorly managed pain are all factors of developing a delirium. While there is no gold standard screening tool for malnutrition, the mini nutritional assessment, the M&A tool, was developed specifically for screening malnutrition in the geriatric population. The M&A and a shortened version, the M&A SF, have been used internationally. Both are available in 30 languages and are free to download, and you have the address there. And I'm giving you the handouts later so you can see all the references. Nothing by mouth after midnight is less common today. There is a growing number of organizations who have endorsed liberalizing food and fluid restrictions in patients with no specific risk of aspiration, and now allowing patients to drink clear fluid up to 2 hours before anesthesia. Sometimes can a clear carbohydrate-rich beverage, either apple juice or commercial or prepared formula, be prescribed. The carbohydrate loading may reduce the negative consequences of preoperative fasting, which include postoperative nausea and vomiting, loss of muscle strength, and postoperative insulin resistance. A head-to-toe skin assessment on admission with examination of pressure points on every shift is important strategy to proactively avoid the development of pressure ulcers. Prior to surgery, it is important to ensure that the heels are offloaded and free from pressure. Adequate pain relief, both before and after surgery, is crucial to reduce fear of repositioning. These patients often have poor nutritional status and are fasting prior to surgery, thus increasing the risk of developing pressure-related skin breakdown. Strategies to reduce the risk include introducing an evidence-based pathway that includes early surgery and optimizing fluid and nutritional balance, which are clinical imperatives for these vulnerable patients. A recent Cochrane review update by Kokos and colleagues agrees with current guidelines recommendations supporting the use of combined modalities in hospitals, trauma and surgical patients at risk for developing VTE. Nursing strategies include administration, medication within the prescribed time schedule, and monitoring the patient for adverse effects. Early mobilization and adequate hydration are essential components of the VTE prevention. We, as nurses, must encourage patients to mobilize as soon as practical after surgery and offer and encourage fluid intake in accordance with any limitations, of course. In preparation for discharge, patients and their families and care providers requires both verbal and written information addressing the signs and symptoms of VTE, the proper technique for administration, injection, and the importance of taking the medication at the appropriate time and for the prescribed duration, and mobilization and structured and to maintain adequate hydration. Catheter-associated urinary tract infections are common. We have to routinely screening for UTI at admission that can identify patients earlier and lead to earlier treatment and prevention of ACORTI. The criteria for avoiding the development of ACORTI include ensuring the insertion is clinically necessary, use of an aseptic technique when inserting the device, removal of the device as soon as possible when it's no longer needed. The goal of rehabilitation is that the patient will regain as much pre-fracture level of function and health-related quality of life as they had before the fracture. Use care planning protocols and encourage and support patients to be active participants in their self-care activities. Early mobilization is essential. Nurses should ensure patients have the sensory aids in place and that the pain is managed in anticipation of ambulation. One of the most common used and most effective approaches to fracture management is the fracture liaison service. I hope you all have that in place. Otherwise, I know Hannah will have a workshop later on here today. And this is my references. Thank you.
Thank you very much. Just in time. So, are there any questions to Professor Hommel? There's one. Yeah.
Thank you for your presentation. One question would be also, as we have heard, this sensorium new stuff that is existing. Do you use such equipment in your university hospital in Monmouth? For example,
No.
alerting from delirium, or if they move in the room?
No, we have sensory equipment on the bed, so we can be alerted when the patient is going up, but we don't have these things on the arms and on the wrist. I know there are some studies going on with that, but I haven't heard any hospital in Sweden that are using them. But you have them on the beds and on the floor and so you can follow the patients.